If you compare it with the size of the tumor right now, is, I would say, maybe more than 60% less. We want for a lot of our patients to do some kind of testimonial, to talk about their experiences, because there's sometimes a little bit of reserves to come to Mexico to be treated, Mexico City or Cabo. And we also want to know your updates or your thinking about this experience. So if you allowed me, I will start by the main thing, that is how you've been doing, how you've been feeling. Is there anything that we can do for you at this moment?
No, I don't think so. I had some testing and some pathology, and that all looked good. I feel good. I go to work every day, and that doesn't seem to be a problem. And I have since February of 24. Sorry, yeah, February of 24. So that's only a few months after my treatments, of course, and I guess. Previous to my treatments, I had a hard time getting in my truck, so there's quite a change in a short period of time, and it's continued. My weight has come back, and my muscle mass has come back, pretty much to how it was previous to all this. So I really don't have anything to ask. I have really no ask. Your guys' follow-up has always been really good, and no, I'm good.
Excellent. So, well, I think that you already know the result of the PET-CT. Of course, it's great for us to see that thing that you still have in your liver is almost all cystic. It's like no viable, not like living tumor. You can see a lot of fluid inside that rounded mass, and of course that can be taken care of. I think that we even discussed that last time we talked about it, to try to drain, to take out that fluid. But every time that you put a needle inside your body, there's always a risk. So if that is not really causing big trouble for you, that eventually it can be absorbed by the body, or even it can be like surrounded by fibrous tissue, and you can live with that cyst like all your life. Okay, so that is not a big issue unless it get bigger, or if that is making you uncomfortable.
No, actually, we went to Cabos in early July, and actually they did try to drain it at hospital H. And it was too thick of a fluid, and Dr. Williams didn't want to risk, so they just took some pathology samples from the lab,
and they came negative. So yes, I am aware of that. I always keep track of everything that they do in Cabo, even though that I cannot be there all the time. But yes, I am aware of that. And let me put it this way: this is a teacher of mine when I was doing my interventional radiology training. He always told us that when this material is so dense, it's like if you try to take out a dog through a straw. So it's better to leave that material in there. If it is not cancer, if it is not pus, it just can be inflammatory fluid, and it can be let alone. Okay, so yes, I do agree with Dr. Williams on that.
Yeah, my oncologist up here, they had a concern as that they felt that inflammation or that contrast that they were seeing was possibly a recurrence, but I guess that's one of the reasons I went down there, and that was ruled out. So that was really great to hear that it was inflammation, and Dr. Williams was 100% sure, and that was terrific. So, and I mean, it's shrunk. It's probably in volume. It's probably shrunk have to say. I just started shrinking before I even left Cabos, and yeah, it doesn't bother me at all. So
That's great.
Yeah.
That's great.
The most
Nothing
important
there.
part is that it's just fluid. But it's dead, right? It's just nothing, right? So, like you said, as long as it's not bothering him, he can just keep on keeping on.
That's correct. And of course, we will need to do follow-ups. It's not something that we need to ring the bells and let it alone for a long time. We prefer to keep watching, keep doing studies, just to be sure that everything that we did was as we want, to be beneficial for you and knock out completely the tumor. That's the main goal. That's always our idea. But we have to be wise and not to forget about it, so we can continue doing imaging follow-ups, either ultrasound, CT scans, MRIs, whatever is needed, so we can be sure that this tumor is not going to come back. There is always that risk, that possibility. And that's why we need to keep watching it. So it's just to be sure that we completely knock out that tumor, okay?
Yeah, I talked to my oncologist up here and told them they were looking at doing some mapping and possibly some Y90, and of course I said no, we're not going to do that after talking to Dr. Williams. He said probably the worst thing they could do, but they were terrific, and they said that they'll keep doing imaging every 3 months, different types of imaging, and it'll just be on surveillance for now, and that's fine by me.
Yeah, I think you have 2 appointments scheduled, one for ultrasound with contrast and then an MRI here in November, I think. I think there's, your next one's there because, the last one we're at the PT was at the end of July, and so then the next one is in November, I think, Dad.
Yeah, I've got that information, and of course we'll send the imaging down to you guys as we always do, and no, we certainly want to follow up with you guys, and you guys have actually been terrific with the follow-up.
Okay, that's great to hear. Now, if you allowed me and if you agree, it's not going to be like an interview or nothing like that. It's just for us to know your impression, like I would say a testimonial, so you can share your experience, if you allowed us, with other potential patients or with other ongoing patients, so they know how what they can expect for the treatments here with Williams Cancer Institute, your outcome, of course, and share with others your experience. So if you allowed me, please let me know in general your opinion on our treatments.
Well, I guess one thing that always kind of caught my eye when I kind of found you guys or was pointed in your direction. The treatments are so uninvasive that it was very, very surprising, and really everything was very professional at hospital age there, and it was really all top notch. It was hard to understand how a procedure so uninvasive could be so incredibly effective as well. But at the very start, what always kind of drew me to Williams in a way was that you go after where the problem is. It's not systemically your whole body. You go where the problem is, and it works out from there instead of the other way around. I guess is that sort of what you mean? I guess.
Yeah, and of course, if you can share also, what were your expectations to be treated in Mexico and not in the US? Were you, I don't know, afraid or with some reserves about the language, maybe how you are going to be treated? I don't know if you have some concerns about those things, and what happened after you were treated?
Well, of course, going to another country and Mexico, of course, you hear stories, and potentially there are some places that aren't reputable, But no, going there, it really didn't bother me, especially after talking to Jessica and Angie and Dr. Williams and the consultation. I was quite comfortable going. I've been to Mexico many times as well. I mean, they're not. It's not a place that really concerns me about. So.
Okay. Well, I can see that Dr. Williams just joined the meeting. Hey, Jason, how are you doing today?
Good, good. How you guys doing?
Hi, Dr. Williams.
Great, thanks.
Good to see. How things been?
Good, real good.
It's I'm gonna pull up. I've got to pull up your images and stuff as well. I'm hearing.
And then when we got to Mexico and just all the professionalism, the hospital H was terrific, and it was really it was all top notch. I always wondered how after being treated, how the follow up would be. Would I just get treated and then kind of that's it? But it wasn't like that at all. The follow up has been fantastic and been with me all the way. And it's tough because I'm dealing with oncologists up here where standard care is standard care, and there really was no hope for me here. It was basically probably in a year you won't be with us, and that was 4 or 5 months over a year now. So.
Yeah, I do remember the first time we spoke that we even saw part of your images. We know that it was going to be challenging because of the size of the tumor that you had at that time, and right now there is no more solid part of that tumor. It's all cystic. I don't know if you have something maybe to say about your experience also with our drivers, the nursing staff in the hospital.
Well, Chris, we had Chris both times we went down there, and he was very professional and prompt. He's just terrific. Never concerned there at all. When you first get there, you're getting picked up at the airport. You kind of wondering, everything that's going on. And no, that was easy. As far as the people at the hospital, the English was very good. The care was good. No, it's probably one of the nicest hospitals I've ever been in. We're in Canada here, and we have some pretty nice facilities, but that hospital H was terrific, and for cleanliness, everything it was top notch.
Okay.
It was professional.
And your post-procedure experience after you got treated, did you think that it was going to be like that fast or that less invasive?
No, I really didn't know what to expect, but using needles, of course, it was completely non-invasive. I didn't really have any pain at all with the treatments. Like I said, I'm just a little tired and maybe a little slight fever, but I could get up and get around as good as I could at that time. Anyway, go for supper or whatever we have to do. My son picked a place with 3 sets of stairs, so I don't know. That was a little surprising to start. That was good for me. He made me go in the pool too, so that was good.
All right.
No, that was great.
The Zoom thing kicked me off, and I just was able to get back on.
Oh, okay.
Yeah, I'm just pulling up some stuff here.
Do you want me to share some images?
Oh yeah, Carlos, can you do the images? If you could do the images, that'd be great. Yeah.
Yes, I already have this.
I was gonna pull them up, but yeah.
Please
Yes,
just let me know when you can see my screen. I think that you can right now.
Yeah.
Okay. So, this is you. I want to start, if Dr. Williams agree, with your first study when we just met you. It's an abdominal MRI. And the reason that I want to start with this is for us really see the difference between both studies. So I'm going to this. Okay, so this was you on September 21st.
Yikes.
Yeah, look at all that. Yeah.
And this, let me put the PET CT. So this is you, the last study that was in July, okay? So you can see the change in the way it looks, these more solid areas, and the size of the tumor. If you compare it with the size of the tumor right now, is, I would say, maybe more than 60% less than it was. And of course, there is no more solid areas. What we might be looking at is this area here, but this can be inflammation. And I don't want to be like too optimistic. I always try to be, but as I told you earlier, we have to continue doing our surveillance, to keep doing imaging studies, just to be sure. But if you compare where you were 1 year ago and where you are now, it's like two completely different patients. I don't know, Dr. Williams, did you have some?
Yeah, the thing, and of course we know we've sampled the area in there and got a lot of more inflammatory cells and dead cells. So we know that all areas probably is necrosis, and this should probably heal. And so, and ultimately it will normalize. I mean, it may leave a scar, may leave a cyst, but in all likelihood, the cancer probably is gone. And obviously, we're going to keep watching for it and seeing. But yeah, that's the results that we're seeing.
Definitely a big change. The lesions, I had probably 4 or 5 satellite lesions that were. Yeah,
if we show, I think Carlos, if we show more, there's probably we can show that it was more extensive originally.
Yes, you can see in the right below that they were almost to the lower part of the liver.
And then is there another scan? Is there another like a PET scan
from before?
From before, yeah.
This was the only PET. This is the only PET scan I had.
Yes, I don't have any other PET CT.
Okay, all right, yeah, okay.
The lesions, they aren't even detectable on anything I've had up here for probably 6 months now either.
Yeah, what we see in these cases now, because obviously this is a different type of way of treating cancer, where you're going directly into the tumor, so things respond differently, and you see where the cancer kind of goes away, but there's residual like inflammatory cells staying around it, so the tissue doesn't go back completely normal. It may go back to normal, but over a long period of time, but the cancer is kind of like going away. It's really like the immune system goes in and kills the cancer, but then it leaves like forces around in case there's a cancer that shows up. It's like you fought a war and you leave some military behind after you finished your war, to kind of keep things under control, and that's what the immune system does.
Yeah, that was the part that they were concerned about up here, because they don't really understand that.
Yeah, it's a different concept, and so. Yeah. And a lot of times now, that because we're doing things in this direction, they don't understand it. They've never seen it go this way before. So it really is like shocking to them, because that's not the way traditional treatments will work. But immunotherapy is completely different.
Yeah. Oh no. Yeah. They were surprised at a lot of things, actually.
Yeah. So obviously this particular, obviously we're figuring out all the different cancers, but hepatocellular carcinoma, I think we really got its number. I think we really have the thing that works well for all of those. This should become the standard of care of treatment for all patients with HCC, but really should become the standard of care of patients with all cancer, that you go into the tumor and you treat it first. You can still do stuff systemically if you need to, right? But why just always do things systemically and not hit the tumor? You have to hit the tumor as well to take that down. That makes no sense. It's like saying there's a neighborhood, there's a house on fire, so we're just going to spray water over the entire neighborhood, but not directly on the house, but the whole neighborhood, right? So that's kind of what they're doing.
Well, that's one thing that really attracted me to your treatment, Dr. Williams, is that you go where the problem is and kind of instead of the other way around. Like exactly like you said with the house and the neighborhood there.
You can hit it from all angles. But you can directly hit it and you can hit it from afar, but you definitely want to directly hit it. I mean, that's the thing that surprises me, that they're always like, no, don't directly hit it. Like, let's just give it stuff from far. Let's just give it chemo from away. Let's give it other drugs that are far, that the treatment doesn't make sense.
What really interests me, and when you see it, so you target it in a different way. When they say they're going to target the tumor directly, they're cutting you open and taking it, right, which is very taxing on a person who is already in a very vulnerable state as well. Right. So this is non-invasive. It's going directly to the problem, but then at the same time, and we've seen it with other examples of patients you treated, it kind of works almost as a systemic treatment in its own, right? Because what you put in there, it learns to recognize cancer cells. So it recognizes cancer cells not only in the main target area that you're doing the treatment on, it will go kind of throughout the body and send its army to other places and attack cancer without having any direct treatment as well, which is super cool. So it's almost like a targeted immunotherapy that works systemically as well in certain cases.
Right. I mean, you're targeting and you're doing it systemic. You're hitting like both areas. Yeah, the thing is really interesting with this, that I think in the future, all cancer would be like you identify a person with cancer. You won't want to mess with it. You don't want to disturb it. You don't even want to biopsy it, because biopsying will inflame it. You will go into it. You will say, okay, this is probably cancer. We're going to start treating it. We're going to maybe do ablation. We're going to inject immunotherapy. We'll sample it while we're treating it. That's when we get our biopsy. That's when we get our sample. We don't biopsy and then wait later and then treat, right? Because you biopsy, you inflame it, the cancer gets mad, it grows, and then what? You're treating weeks later. That's not a good option. So you treat it, at that time. But that's the future, is that you identify those suspicious lesions and you don't mess with them, and we'll just go in and we'll start treating, and then we'll sample, and then we'll move forward in treating and do it that way. And that's going to get much better results.
Certainly has.
Yeah, that's the future. I mean, that's the future. I mean, that's how it should be done. We're making huge mistakes by like saying, okay, this person has a lesion. Okay, now let's send them and biopsy it. Oh, let's wait a few weeks. Now, okay, let's cut it out, or let's give them chemo or give radiation. Like, that's a terrible mistake. It should not be that way. It should be like, okay, this person has something suspicious. It's suspicious enough that we're gonna go ahead and we're gonna treat and sample at the same time. We're gonna know. I mean, we've developed some needles that will tell us that you're in cancer. So we'll be able to do these type of things in the near future, where you won't even need the pathologist. But you could have the pathologist come. You could say, okay, let's treat. You confirm with us this is cancer, and we're going to go ahead and treat. But you shouldn't disrupt the tumor in any form, surgery, biopsy, or any way, without initiating a treatment at the same time.
Yeah, I mean, when I was first diagnosed, and like I've told you, they basically said, you got about a year, just basically go home and get your stuff in order, weird stuff like, should I buy a new pair of shoes? Well, geez, I don't know. Or even glasses. I need a new glass. Oh. You know what I mean? It's just a different way of looking at things. And like, even if they would have told me that they were going to do surgery and try and cut it out after they told me I was going to know, I probably would have been okay with that, because they weren't going to do anything anyway. But then I found you guys, thank God, it's a different world.
Yeah. Hopefully this is the future of cancer treatment, that patients don't have to go through major stuff. I mean, you really, you want a cancer patient to come get their treatment, give her their cancer, and leave them the same way that they were before. You don't want to like mess them up with stuff, and that's unfortunately that's what's happening with patients, and hopefully the system will change.
Well, that's the best I've felt in a couple of years. I mean,
that's great.
That cancer was growing and it was affecting me. I just didn't know it.
Cancer produces substances that makes you feel bad, right? It's cancer to stay around needs to make the immune system allow it to stay, and so it makes substances that makes like older cells hang around. Cancer is an aging process, is what it does. It ages the cells around it, and then it ages the immune system, and so it does that to survive. And so that's why it makes people feel bad, and it's doing it, to try to survive itself. but it's surviving in spite of your own body, right? It has its own agenda. So yeah, it's but we're getting all these things figured out now, getting all the different ways of different cancers. I mean, there's differences in immune responses. Cancer like yours, I think we've got it pretty well covered. I think this is a cancer that we can really take down. This should be treated this way, and hopefully we can get some good clinical trials and other stuff in the future, and get this as like a standard approved therapy. I mean, this should be what everybody, what you got should be what everybody with your condition should get.
Yeah, I agree. I mean, I'm sure you keep statistics and everything. I hope they actually use some of that stuff. You're gathering
information. Cancer is rampant in Asia. It's a high amount in Asia, and so they would really benefit over there from it as well, because they have a lot more incidents. But yeah, still, and this applies even to other cancers, of course, and other cancers that have spread to the liver as well. So yeah, but this is clearly the future of medicine. I mean, what I see in the future will be that you have the images, you will have a robotic system that will help you guide putting the needles into the tumor. It will communicate with a computer system that will be an AI that will say, okay, like the tumor DNA is this, microbiome is this, all these other things. This is the thing that we created that we call Cancer Care AI, and it will say, these are the medications. These are the medications that person needs, right? And then basically the robot would have it like an inkjet printer. Well, the medications would be loaded in it, and it would like administer into the tumor based on that person, right? That's what I think we'll see. So yeah,
you're definitely getting there. That's for sure.
Yeah, that's the vision. That's the vision that I have. Seeing it, we're basically we're us as physicians, we're there helping and overseeing the robotics, doing a lot of the stuff, but that would be kind of the way that I think that things will go.
Is there anything I guess I should be looking for? That might indicate I'm not feeling well or something.
No, but I think the main thing is, are you following like some of our supplement stuff that we recommend?
Yeah,
a lot of that, things that help keep you younger and healthier, which are a lot of the supplement stuff that we recommend, are things that are good to be anti-cancer. So there's a lot of stuff that they don't talk about being anti-cancer. Like the supplement for scolin, also using now I don't know if we have you on this. Valproic acid is actually a prescription that's anti-cancer, and then there's a few other drugs that you work with that can be anti-cancer as well. So I don't know if we want to check and see if we have you on all those, or we can try to get you on some of that. That will help reduce your future cancer risk.
Okay, well, what I'll do is we're just rounding up a couple of ones that you suggested. Maybe what we could do is make a whole list of them, and we'll send them to Angie or whatever you guys.
Yeah, let me get between Angie and Dr. Goodyear and those guys, and like get you on stuff, because like I know sometimes it's challenging to get some medication, but we'll make sure that we get you all the stuff that will help try to keep you healthy, and will significantly reduce the chance of not only this cancer but any cancer coming back, right? It's amazing. There was a study with valproic acid with head and neck cancers in the military patients in VA, and reduced their incidence of developing head and neck cancer by 50%. Patients who took valproic acid, and that never really went anywhere, right? I mean, lots of the studies that reduce cancer, but yet they're not telling people about it. Right?
It's just such a shame that the politics of the world and even big pharma and business gets in the way of saving people's lives. It drives me nuts. It is for you.
It is. It's a little crazy. I think we need definitely now that I think we've got good treatments for cancer coming, but then I think we need to be able to focus on keeping people from getting cancer as well, and I think that will be the next thing. And so we don't need this high incidence of cancer that we have. We can be able to prevent people from having it, and so that's what I'm working on. on my upcoming book, I think I'll touch on all that. So I'll come up with a new book that will help guide people along these things.
I think you're at Rad this weekend.
I did. I spoke yesterday. I think I blew everybody away. I think they didn't even understand exactly what I told them that we know.
I can't wait to see it. We do have the forskolin and sodium.
Oh yeah, sodium butyrate. Yeah, those are certainly important. Yeah.
I've always been taking the camu and the daily 3 times a day. But I'll send her a list of everything we're taking. If you want to add to it or even take from it, that's fine.
Yeah, we'll check and see, make sure. Just a couple things that just might help kind of boost you, just for your overall health, right? Is that?
Yep, that's fine.
Like, I think we're good on the cancer front. I mean, I think your cancer is going to be good. I mean, if this cancer, I believe it's probably gone. But if and if it comes back, we would just, we could make it go away. I mean, look, we made it mainly go away now. So, but I think it's probably gone, and I think we're going to keep it that way. So.
Well, what I always come back to is those lesions. Like you didn't. I mean, you injected there, but you didn't do any ablation. I don't think on any of the lesions because they were smaller, right? Don't know that for sure, but
usually we do like a focal ablation, but we don't ablate everywhere. We do. It depends on the case. We are, I think, getting good enough now that we can actually do this without ablation. I think we can do this all with drugs. But
really?
But yeah, I think we could do that. But we do kind of throw in the ablation as insurance. So we're gonna add that in just to really boost the response.
But your immune system, you don't completely destroy it, so your immune system can recognize it.
That's right. Yeah, and that is interesting, and I was involved in the paper that came out on that. It was published by Alex Huang's group at Case Western Reserve, who I had advised and was their advisor. They did mention me on the paper that we showed that if you ablate part of the tumor, you get immune stimulation, but if you ablate all the tumor, you don't. So that's the concept that the other radiologists are not understanding. They're saying you got to kill the whole tumor, right? This is the idea. They think you got to kill the whole thing, but that doesn't stimulate the immune response. So it's actually killing part of the tumor. And what we showed was that you kill part of the tumor, and the tumor itself begins producing immune stimulating substances. Oddly enough, right? I mean, the tumor itself does it, produces something called STING. And so that was a paper that we came out about, almost 2 years now, and really should have transformed the concept of how ablation is done, but I don't think people got it. I don't think they understood it. We're trying to see if we can
help so many people and really save billions and billions of dollars in healthcare.
Oh gosh,
it's crazy.
Yeah, when I look at like the stuff, I go back through the research and I think of like, how did they miss this stuff? There's so much stuff that they should have picked up. We should have been way more advanced than this 20, questionably 30 years ago. I'll be honest with you. Yeah. Wow. I mean, I look at it and like the technology was there. I mean, we really should have made a big leap in the early 80s. And it didn't happen. I don't know why. It was kind of, a lot of it was, because everything's compartmentalized, and they do these projects and they're like, oh, and I noticed this is what I experienced. And now I'm like kind of going back through my history of like the work that I did when I was younger and started thinking about it. So when I was younger, I worked on various like DNA sequencing, and we were looking at like DNA, like p53, and I had this like lab. I was young, I was 20, and they gave me like my own lab to work in. I had like all this stuff, and this professor said, "Hey, I got a project for you. We want to work on ALS. And what do you think you could do with it?" So I was like, let me research a little bit. So look, I was like, okay, well, if they found that the mutation is a superoxide dismutase, is like the genetic form of ALS. Now there's other forms we don't know. So I can make an RNA that will bind to that antisense RNA, and block that, and that would probably treat the condition. And so they're like, okay, that's interesting. You go and do that. So I go and I do that, and then I finish. I'm like, okay, so here it is. And it's like it's after 2 weeks, right? And I go and I'm like, here's the project. I worked on this with ALS, and I made an antisense RNA. I mean, RNA that binds to the mutated form will block it from forming, so that gene's not expressed, and would treat ALS. And they're like, good work. And I'm like, okay, what do we do with it? They're like, well, that's it. And I was like, but is somebody gonna like take this to people, or like, I'm like, what's gonna happen with it? And it just stopped. Now this was 1990, so and it wasn't just that. It was like, I was involved in several projects where I did things, and I would tell them, hey, this is what we're seeing. Okay, we're curing all the mice with cancer with these things, and they're like, oh, great. And then the project ends, and it goes nowhere. It's done. It's like they're like, yeah, bro, write a paper on it. So I'm like, I don't really care about paper. Like, how are we going to get it to people? They're like, well, the funding was only for you to demonstrate that, and that was it, and it went nowhere. And I kept wondering, like, how's our research like? We're doing this work, we're showing that we can do these things, and then nobody's taking it. Nobody who's like, isn't somebody supposed to jump on this and say, hey, yeah, this is great therapy, and like, let's take it somewhere? But that wasn't happening. So that was the thing that really surprised me. I mean, it surprised me that the therapy that I actually worked on to develop with ALS, that therapy actually finally came out later, 20 something years later, right? Like, I mean, yeah, I mean, that's crazy. But we did it like early on up front. So we were doing all sorts of stuff. So
yeah, and I mean, you're doing that, and there's other people doing other things, and they just stop too. Like, it's just
we had our laboratory stuff in New Orleans between LSU, Tulane, and Oxnard, and we had crazy stuff. I mean, crazy stuff there. I mean, like, I like, and I'm talking about like when you enter the building, 5 levels of security to get through. We had transgenic animals. I mean, so animals that we had made part human to do research on, right?
Oh,
yeah, no, like crazy stuff.
I don't see why fund the research if you have no plans if you get good findings to put it into action. It just, to me, it's just a waste of money then.
That's what I thought. I kept wondering, like, what are we doing? I mean, I'm a student, and I'm most of my stuff is I'm a volunteer, right? I'm not even getting paid. Eventually, they actually gave me a job that they paid me $10 an hour to work as a laboratory person, and I had my own laboratory, and then I collaborated with the other groups, and we had like our stuff, and I was doing all sorts of stuff. Like every week we were like making like major discoveries. I'm 20 years old, 21 years